and welcome to Profit's Healthcare Transformers podcast, where we'll be talking to leaders in healthcare who are focused on transforming their organizations to drive the next level of growth for their business and for healthcare. Hosted by Priya Anasia, Lindsay Mosby, Paul Schrimpf, and Jeff Gorgie. Transformation is one of those terms that has a lot of layers to it. Sometimes it's about innovation. Sometimes it's about shifting the way you do business. Sometimes it's to your overall operating model. And other times it's to a specific department or function. It's also about people, helping them navigate the discomfort that comes with change, but also motivating them to engage in the journey of transformation from the CEO to the newest employee. It's a journey, and that's why we created this podcast, to break down this multidimensional, dynamic topic of transformation, one story at a time. Are you ready to dive in?
Hi, I'm Jeff Gorgie.
And I'm Lindsay Mosby. We are the hosts of today's podcast.
We are pleased to have with us today Dr. Alistair Erskine, the Chief Digital Health Officer of Mass General Brigham. Alistair, welcome.
Thank you. Thank you, Jeff, for having me.
Tell us about yourself and tell us one fun kind of personal tidbit here that's maybe off topic.
I see. So I'm a physician, internal medicine and pediatrics. I guess one thing, I have 3 kids that are all teenagers. So that's been an interesting experience. And the thing that I enjoy doing the most is sailing. I always look for work alongside waterways so that I can sail.
That's awesome. I wish this podcast could provide you some opportunities for that, but sadly we can't. Alistair, tell us about your role. And I'm curious, particularly if it's the case, like when was it created? Are you the first occupant of the role? And if you were, what was the genesis of creating a Chief Digital Health Officer role for the organization?
Actually, I am the first person in this particular role that was created about 4 years ago. And I think probably the best way to describe kind of how it came to be is going back a few years in terms of how physicians were getting involved into informatics and helping out with, prototypical electronic health records. You start off as a champion, kind of sitting on some committees, and you had some protected time. We could take on a formal role. Then the role of the CMIO, the Chief Medical Information Officer, came along that was really primarily focused on the electronic health record. But that wasn't sufficient to be able to manage all the healthcare transaction. That sort of started to ease into the data side. So as the data side and as some of the care management aspects started to expand, you started hearing about these roles of Chief Health Information Officer, which was a bit bigger than medical. And then as the role continued to expand in terms of its scope, especially as the consumer side came into view and people started moving into that space, this digital health officer role came to be. So it's really kind of been a progression. And I think that the next role beyond this will be a chief information and digital officer. So that is something that I'm noticing that is becoming more common. That full scope of activity, both platforms and service delivery, I think will be what that next group of leaders will go. But for now, I'm quite happy as a chief digital health officer.
So Alistair, how much time do you spend practicing medicine?
The official answer is only a few weeks a year. The unofficial answer is it kind of depends what you mean by practice in medicine. So I'm board certified in internal medicine and in pediatrics, but I'm also board certified in clinical informatics. And so the question ends up being, is that a practice of medicine? It's a board specialty, subspecialty, and I certainly do plenty of that all day long. And maybe when the field finally matures to the fact that clinical informaticians are on the front lines and are part of the clinical team and are providing assistance in terms of when to use this AI or how to use that algorithm or how to interpret that decision support or how to go off and find patients like the ones in front of you to see what kind of data and predictive analytics can be performed. Maybe that's when it really will be considered the practice of clinical informatics. But for the time being, I think we're sort of in this adolescent stage.
Yeah. What was the aha for you as you kind of, all the time that went into medical school and getting into the practice of medicine that said you could create more impact in a different way? Was there an aha or a singular moment?
It was a very specific and singular moment, as a matter of fact.
Good.
I'll try to describe it. So I'm sitting at the nurse's station and I'm writing a note on the neurology floor. It was a consult note for one of the neurology patients. And I look over at the unit clerk who is carrying a recycle bin closer to her desk. And she has taken reams of paper off of the printer and directly put them into the recycling bin. And so as I'm writing, I'm thinking, and I look up and I'm thinking, okay, what's going on there? Because there's got to be a story, right? And so what happened is these reams, and I went to her and asked her, and she said, well, look, it's quite annoying. Every single morning, every afternoon, I got to feed this thing. And then nobody looks at these things, so I've got to go and recycle them. And it's something I do every single day. So long and short of it is that reports had been created several years ago and were being distributed to every single unit on every single floor. And something to the tune of millions of dollars worth of ink and paper were being spent on this. That's something that people weren't using and actually would take time away from a busy person at a unit. So I thought, wow, this is great. I'm going to be able to go to a committee, and in a couple of minutes, I'll be able to tell them, you know what, turn it off. And then we can save, all this time and energy and effort. And what I discovered is when I went to the committee, whatever it may have been, and said, turn it off, people were appalled. And I was hooked at that point. I thought, oh, there's something here. The idea that the actual practical implementation of technology is distant sometimes and foreign to the concept of it and the idea. And in fact, so many times subsequent to that, I would sit in a room full of my colleagues and very smart and intelligent people who would come up with a really clever process. And then I would go back into practice and thought, this does not work in the hurly-burly of clinical care when beeper going off and being called away and the computer not being nearby and having to log in, whatever it may be. And so I really got hooked on the application of technology on the front line and the impact of technology on people in the real world.
So give us a circa 20 years ago, 10 years ago.
So this is 2001. Many more examples of that subsequently, but that was a defining moment. It was more about what is your actual clinical workflow as a doctor? What do you actually do? What is actually important to you? It wasn't the technical expertise that seemed to be valuable. It was more so the clinical workflow experience that I had and the ability to be able to translate that as a Rosetta Stone into business specifications that could then be digitized or put into a process.
Got it. So when I asked the question, obviously, did you help create the role? It's because we're hearing more and more about first-time chief digital officers, right? Or people who created their own job spec and worked with their management team, but they're relatively new to it. And I think it's probably fair to say one of the pioneers, perhaps, right? Going a couple of decades ago into it. I
can think of many pioneers that came before me that I was able to jump on that bandwagon. And it was a time where CMIOs was still very new. And in fact, it was as difficult as me handing a piece of paper to my boss and saying, I kind of like this title and this role. What do you think? And he's like, okay, sounds good. And that was about it. There was no fellowship training program. There was no years of experience that people had at the time because it was still fairly new.
So we're going to weave here, if we can, between kind of your path and career and just kind of Mass General Brigham and the current and future, if we could. So 4 years ago, the role was created. What was the agenda or the emerging need that said we need to do this? And then maybe take us from there to the current day, where you said to us, prior to this conversation about a digital transformation journey that's underway at Mass General Brigham.
So at the time, I actually came at a really good time in what was referred to as Partners Healthcare back then.
Right.
It was the tail of the sort of overall implementation of Epic. And this is after Partners had tried everything else and then finally relented and then ended up choosing Epic.
Yeah.
And a very clever set of folks chose to do one Epic enterprise build as opposed to the federated system that Partners really was, with two big academic medical centers, Mass General Hospital and the Brigham and Women's Hospital, decided to go with just really one system. And so I arrived right as we were finishing up each individual implementation. It was time to optimize and to augment what we were doing. So beyond the traditional electronic health record and more towards consumer experience, provider experience, the researcher and research participant experiences, and trying to improve, going from some of the digitization that had occurred to redesigning those workflows to take advantage of the digital tools that existed. That's really what I started with. So I really started, and by the way, at the time, they was the largest single instance implementation of Epic that Epic had done. COVID helped get us catalyzed. I think the consumerism piece definitely helped as well. And then this understanding and appreciation for the fact that labor is the most expensive part of healthcare. And therefore, automation and improve business processes was all part of what needed to occur for the transformation process.
That's great. I'd love, Alistair, if you would paint a picture of the state of consumer centricity 3 years from now at Mass General Brigham. What is the consumer going to feel, experience, and how is it going to be different from today?
We are inheriting the advances that the retail, travel industry, other industries are setting expectations to the consumers in healthcare, which is a very good thing. And 3 years from now, we will have many more transactions available online and many more manual transactions, even voice transactions that are helped with online, with what I would say digital tools. So I'll give you an example. If you call the call center, today you get a human, and that human may or may not have access to information in your medical record. So if you need to make a primary care appointment, you have to tell the agent who your primary care doctor is, maybe spell their name, and then they find it, and then they help you book that appointment, almost manually voice. In the future, that really is not necessary anymore. First of all, the computer will listen to the questions that you have and decide whether at that moment you need a human or the computer can help manage that conversation by itself. And that's even true for booking an appointment. So we have, again, this idea that the technical tools that we have, the digital tools, really should be able to be applied to any and all patients, not just the ones that are savvy with smartphones. So going back to 3 years from now, the website that the person visits will be more tailored to their specific type of need. So if they're a diabetic patient, they'll see diabetic type of services. And we'll use standard industry ways to be able to know more and the propensity of different consumers to have interest in certain things. We will create an experience that will be much, much closer to a retail experience in terms of the stickiness that you end up having in the market and in sort of care taken. We want patients to get great care, but we also want to make sure they're cared for during their journey. And I think that's the part, the second part is the part that's really missing. The patient today has to serve as their own care manager and connect the dots between they have a surgery to the physical therapy appointment. And we want to make sure that that is premeditated and scripted out and that the patient can sort of be on that journey. So in order to be able to do that, the patient will enter basically a mall on the website, and that mall will have a number of different stores. And one of the stores will be the patient portal. They could be, again, things about hypertension management or diabetes management or how to prepare for surgery, how to meet your care team. And this mall, this patient gateway, essentially, that we will create will help us understand ultimately what patients are looking for, where there's a gap, and do a much better match between what the patient really needs and what the healthcare services are that are available to them in a location that's more convenient to them, in a time frame that's more convenient to them, and with the right sets of language and cultural aspects that are required. So I think today it's a bit one-stop shop, and I think it still requires a patient, if they have a heart problem, to know that they need to go see a cardiologist, that's an electrophysiologist for heart arrhythmia. Those are jargon words in the healthcare space that are just unfamiliar to patients.
Right.
Instead, a patient should be able to say, my heart rate is not normal, and we should be surfacing the right specialist without having to expect the patient to understand the lexicon and the jargon of healthcare.
So let's stay here for a minute. Data is clearly a currency, right? It is 100% a currency. And I think if we watch what's happening in the financial services industry right now and how decentralized, safely anonymized, and democratized platforms like the blockchain, like the cryptocurrency markets that are popping up, that's upending the nature of the financial services industry and the way that they handle data and who has access to it and who gets to quote unquote own it. I think we can only imagine that that's coming for healthcare, that interoperability, that ability to use things back and forth. Everything that you just said speaks to the need to be able to share and exchange and manipulate data. What are the signals you're seeing that's coming, or that people are starting to think differently about? We don't own this data, we broker this data? And are you seeing signals that make you feel like, yeah, we might be able to get there?
The first thing that pops into my mind as you describe that is regulation and privacy are major important components of managing that data.
Of course.
And on the blockchain, part of the problem is also the fact that data is mutable all the time. It's constantly changing there. Just to give kind of a size and proportion, we're doing approximately 53 million transactions on the database per second in our system. So on a blockchain, that would be, for something like that that's affecting the patient's chart, the blockchain would do a good job of saying, all right, I want to access this person's record, and I'm going to be able to sort of log in the fact that I'm accessing the record, as opposed to storing the electronic health record on the blockchain, which would be, I think, overwhelming. But your point about, really, it's about sharing and interoperability and trying to squeeze all the different ways that we capture clinical data from humans into something which is kind of a Rosetta Stone and is standardized and normalized so that other people can interpret that blood pressure that came from this organization is actually a valid blood pressure in that organization. There are two key things that are missing in the industry. One is the universal healthcare data model that everybody agrees to that is comprehensive enough to be able to handle all the healthcare transactions and different data types, all the way from information in a row of vital signs all the way to kind of ultrasound images and so forth. The second major thing that's missing is the vendor-neutral healthcare app store that sits on top of the platforms and transactional systems. In fact, a platform is supposed to be extensible. That's the whole benefit of a platform. But it's not necessarily as extensible as it has been in other industries. And since you're interested on the innovation side of things as well, that is a major gap. And it's not a gap because we don't know how to do it. It's a gap because, there are key players that do not want this to happen. And so this is something that the Office of National Coordinator has understood many years ago and has been trying to promote by having certification, for example, of certain key standards like the FHIR standards and other standards and so forth, and forcing the electronic health records to create APIs. But we haven't gotten to the point where there's a robust enough adopted set of APIs that you can read and write back to the point where we can have a thriving ecosystem. In fact, if you think about an example of Apple and the Apple App Store, of course, that's a good example of the kind. Google Play would be the same thing, but Apple makes available to the general public Swift, which is the language that you write your apps in. And then various different people around the planet and the collective genius of the human race writes in this Swift code all kinds of clever things that sit in a reproducible way. This is not how I would describe how healthcare is being built. You have big monolithic systems and thousands of digital health applications that try to bolt onto it. And what you end up with patients that have a fragmented experience, providers that are burning out with pajama time and working late at night, trying to kind of catch up on all this. And there's a real impedance to that innovation as a result.
What do you think the magic wand is, right? Like if I think about other industries that have been have faced reckonings, right? That the establishment has faced reckonings. What's the potential reckoning for the Epics and the Cerners of the world, or those who right now are kind of holding on to the bulk of the currency, if we keep calling data currency? What has to happen for that to get unlocked?
Let me be really clear too. I do not want to demonize the electronic health record at all. I don't. In fact, I think they have done an enormous amount of good in the applications they're being, because the applications are safe. The applications are stable. They work. Right. I've seen plenty of little digital health apps that blow up after 6 months and they don't work. So the reckoning is, we saw it in the cable industry where the DOCSIS standard really wasn't a standard until different cable companies came together and said, okay, you can buy this modem, and whether you're working with Comcast or whomever else, it's gonna work. It wasn't until Apple decided to endorse the FHIR standard, Fast Healthcare Interoperable Resources, FHIR resources, that there was a galvanizing effect. And then that standard that had been sort of kicked around ended up becoming now part of regulation, ended up becoming part of every vendor's, new and improved. We're even FHIR, based and FHIR compatible and so forth. So I think when big technology organizations outside of healthcare end up adopting healthcare standards, people pay attention. I think that makes a difference. So What will cause a reckoning when it comes to the vendor neutral app store? I think that it will have to be the demand that comes from organizations that are not yet satisfied with their monolith and they need more and they're finding it's too expensive.
What about the Mass General Brigham business model is going to have to change 3 years from now? And what will it take to get there?
I think what has to change is we want a healthcare team to be taking care of a patient, not a doctor. Yeah. We want to spend the time on closing the healthcare gaps, not just, order medications when they may or may not be required or necessary. So I think we need to make a substantial move away from fee-for-service to value-based care. By the way, we're exactly in the process of doing that. So we have created a brand new organization that takes all the community hospitals that we have and all the primary care and specialty doctors that we have in the community and put them under one organization. And that organization also has our health plan in it. They're thinking all day, how do I shift site of service to a site of service that's better? How do I make sure that the referral is distributed across the whole system instead of it just in one academic medical center? And how do I keep care closer to wherever the patient may be coming from and still provide the same level of care? So I think that is fundamental for us to be able, we can do all the digital work in the world. If we're still too expensive and patients and companies can't afford us, it's not going to work. So that means less labor. That means more automation. That means shift inside of service. And that means distributing that, making sure that we have the guardrails for care available everywhere. We have a lot of the infrastructure for that, but I don't know that we fully committed yet to that model, other than the fact that we've said we need to do it. We understand it's part of our future, and we've committed our plan to it, and we're executing against that plan. But I think 3 years from now, we'll be a lot further along in the value-based care journey, onto which we can tack on the population health management, and we can tack on the home-based care aspects of things, and we can tack on the episodic episodes of care as well in a much more comprehensive way.
Well, I know we only have a few minutes left, but I'd love to do one quick pivot, maybe from one version of digital to another version of digital. And I think, there continues to be a lot of talk around and about digital therapeutics. Jeff and I were talking the other day about remembering that Dr. Topol said, they're going to we'll be prescribing apps instead of medicine. What was that, 10 plus years ago or whatever. So I would love to hear a little bit about your thoughts on the current play and maybe the long play around digital therapeutics. Do you see this as something that will continue to find its way into sort of the clinical realm or not? And how come?
Some of the digital therapeutics are fairly fragile in the long term in terms of, what they depend upon. And a good example of that is digital therapeutics that have a number of different AI and machine learning aspects to them, where you start moving those tools to different organizations. Their data is different, and the tool doesn't work in the way that's expected, and needs to really be retrained over and over again, revalidated to make sure that it actually works the way it's supposed to. But the idea that you can move some of the conversation that otherwise happens in a very hurried 20 minutes with a primary care doctor into a home where somebody has a smartphone where they can learn about their particular condition, and then have these touch points throughout the day that reminds them to either perform a certain action or take them a certain medication. It would be nuts not to take advantage of that if that was available.
Yeah. And if a Google Nest is $29.
Right, exactly. Right. Part of the barrier to entry there is, again, sort of this fragmentation that occurs on the digital health apps. If I just have diabetes, then I use my diabetic digital therapeutic, and that works fine. But then if I have more than one medical problem, which, by the way, so many people do, now I'm going to have 5 or 6 different kinds of digital therapeutics that don't work together well at all. And so I'm left as a patient, maybe an 80-year-old lady that has 15 medications, 7 of which have digital therapeutic augmented functions, to try to understand how to weave those together.
Right.
And I think that's going to be a pretty difficult proposition. So I think we have to think about what's the digital divide that we want to avoid. We have to think about what's the digital fragmentation that we want to avoid. How do we wrap this into, and then what's the kind of support that we need to be able to provide to patients and their families and proxies to be able to use digital therapeutics to their full potential.
It's fascinating space, that's for sure.
Dr. Alistair Erskine, thank you. It was a pleasure. We enjoyed the conversation. It was great having you on the podcast.
Thanks for listening to Prophet's Healthcare Transformers podcast. This podcast is produced by Jared Johnson and his wonderful team at Shift Forward Health. And a big thank you to our hosts, Priya and Asia, Lindsay Mosby, Paul Schrimpf, and Jeff Gorgie. If you liked today's episode, you can find more great content like this at profit.com/thinking. I'm Anna Kuno, the senior editor of this podcast. Thank you for listening.